to this interesting session on pediatric corneal diseases and the surgical management, a comprehensive overview. So I request you to bear with me, my throat is not good. And as we all know, the pediatric corneal disease are difficult to not only to diagnose accurately and manage surgically in terms of decision making, choice of surgical technique, and of course post-operative follow-up. One of the major constraints is to provide a clear visual access in order to maximize child visual maturation, particularly during neuroplasticity. Often, the preoperative evaluation is difficult, requiring a anesthesia setup for a detailed examination to ascertain the duration, density of corneal opacification that also helps us estimating the depth of amblyopia. The presence of anterior internatal problem may have contributed to the corneal condition, so that has to be ascertained in detail. So the difficulty increases when it is associated with the various anterior segment abnormality, or when it is associated particularly lens abnormality, secondary glaucoma, retina or optic nerve pathology for the compound rehabilitative journey, meaning keeping the visual axis clear is not good enough in these cases. Therefore, it merits the modification in our surgical technique in order to maximize visual gain. So the comprehensive evaluation is a key. Establishing accurate diagnosis has a direct bearing on the long-term outcome. Determining the visual potential and depth of amblyopia decides your functional outcome. Assessing ocular comorbidity like lid neck cell problem, dry eye, vascularization will directly play a role on a longevity of this graft. Last but not least, not necessarily financial status, it is a social status of a child and a parent is the most important, how badly they want their child to see and how much commitment they can actually put in. This is one of the deciding factor for the most success in a pediatric corneal transplantation. So we have a very stellar speaker and very accomplished speaker, Professor Vanati Murugesan. She is currently professor at RP Center, AIMS. She is also director of Eye Bank at RP Center, and she has numerous interests in advanced lamellar corneal transplant, including a limbal stem cell transplant, ocular surface. She has done a advanced fellowship from SNEC under Donald Tan from Singapore and a lamellar surgery. She has a numerous review publication, book chapters, and she's most sought after speaker in most forms. Next in line, Dr. Somashila. She is currently Director of Cornea and Anterior Segment Services at LV Prasad Eye Institute. Her special interest is uveitis and surface pathology, and she has numerous publications to her credit too. And she would be talking to us on a surgical management of allergic eye diseases in children particularly. And we have Dr. Ramesh, is a senior cornea consultant at Maxivision Eye Center, Vizag, and he's been invited in most forums, including Academy, AOS, SROC, and mainly Andhra Pradesh and Telangana Ophthalmic Society. He would be sharing us a very interesting surgical scenario. And myself, so I'm currently pediatric cornea faculty at LV Prasad. I did a fellowship both in pediatric ophthalmology and pediatric cornea services at Pittsburgh, USA. My interest mainly anterior segment abnormalities, pediatric cataract, corneal infections, and also keratorefractive surgery in children. With this introduction, so I'll lay out our course description. This intended for a practicing cornea and a pediatric ophthalmologist, wherein we try highlight various pediatric conditions and also the visual development and a critical period, and also various surgical modification in order to maximize success. And each individual surgeon, they would share their surgical pearls to efficiently deal these difficult case scenarios. They also present their data and also clinical experience or any innovative approaches they have carried out. Also note this particular date. We have one unique symposium wherein eye in systemic diseases. So I'll go to my presentation on lamellar surgeries.
How many of you here are doing pediatric keratoplasties? By a show of hands, please. Okay. Good? Murli, are you good to go? Yeah.
Oh, I'm sorry about technical glitch. So I shall be talking both anterior and posterior lamellar surgeries. For the next 15 minutes or so, I'll be bringing in various clinical interesting scenarios. I want audience to participate. I do not have any financial interest pertinent to this particular talk. And here is a picture. What do you think diagnosis? This particular child has something on both corneas confined to inferotemporal aspect. You have a midfacial hyperplasia, have a small retracted jaw, low set ears, you have a preauricular tax. So what are we dealing with? Excellent. So it's been said in a published literature, 33% of children who have a bilateral dermoid can have underlying golden hour syndrome. So what is the other synonymous to the golden hour? It is also termed as a auriculovertebral dysplasia. They do have a short neck and it is at times very tricky anesthesia, so may not have a good exposure. So your Mallampati scores are extremely low, so may have a difficulty in intubation. So you generally need a very good anesthetist in your team. And this particular child had a simple excision elsewhere that had not only resulted in a poor cosmesis, poor vision, and also restricted ocular motility. So following a simple dermoid excision, you have a pseudopterygium which is actually extending onto the visual axis. It does producing a diplopia too in this case. On the left eye, where large dermoid, it's not only straddling your limbus and also encroaching upon the visual axis. So therefore a simple excision may not be a solution here. So I'm just opening up conjunctiva, then the tenons. One of the reason is 99% of limbal dermoids are in inferotemporal. The reason is only that small sliver of temporal sclera is derived from mesenchymal. Unlike rest of the anterior segment is derived from a neural crest cells. In other words, ectoderm in origin. This is a mesoderm in origin. So I'm literally shaving off the entire dermoid. It's also very important to take care every bit of dermoid tissue. Although it's not been known to have a recurrence or a malignant transformation, I've never heard. It's very important to prepare your bed. Once you have that, then you can refine. Here I've gone for a very large diameter, eccentric, DALK, deep anterior lamellar keratoplasty, meaning I'm confining to the predesmatic plane, not going very deep, because your desmates naturally terminates at the bottom, at the Schwall baseline, so you can't attempt a big bubble. So it's better to be layer by layer lamellar dissection. So one of the ground rule is that if your residual bed is optically clear, so the depth of the dissection should be adequate. So you need not achieve 90% depth, even if 70% depth, that should be adequate. And most often these cases, we may have to repeat grafting. They're very, very prone for complications. You don't have almost a 1/3 of your limbus, and you have a direct connection here. If you don't have a vertically, if the compressive sutures here, the epithelium can actually come into the interface. You can have epithelial ingrowth, or even at times a vascularization of the interface. And also important to do a torsorrhapy in all these cases. They may have the surface issues, can have an epithelial breakdown, and it can result in a stromal keratitis. And just to show that histopath, this mucous membrane is actually keratinized. It's like a skin-like almost, okay? So post-operatively child did well. One of the other pearl is here, ensure your steroid regimen should be as good as similar to the conventional penetrating keratoplasty. Although it is a DOLC, because you have exposed your graft to the highly vascular network, so can actually incite a stromal resection. Therefore, your steroid should stay for a nearly year time to minimize the risk of stromal resection or interface vascularization or interface deterioration. So I typically keep a contact lens for a little longer time or a torsorrhapy in these cases. Again, to give an example, a simple excision may be a very easy to do, but end up having a complication, something like this. And I did a paid-eye comparison in a 10 children's. One eye by default, as a simple randomization, we did a simple excision with amniotic membrane grafting. The other eye, it could be right or a left eye, had a selective lamellar patch graft. So this actually did a much better in all 10 cases. Therefore, the patch grafts supposed to provide some niche to this limbal stem cells to propagate and to maintain the ocular surface. So it's very important to use wherever possible, patch graft. It could be our desec lenticule, or it could be any other lamellar tissue. And this particular case, which I showed a surgery, so he did about 6 years, he has completed. He has a good vision, better cosmesis. And in these cases, it's better to use a much better quality tissue. You can still see an arcus here. Sometimes even you have a very abnormal posterior chagrin of the cornea, which may actually impair the corneal clarity. So therefore, wherever possible, you can use a good quality tissue in these cases. Are there any questions pertinent to Goldenhar syndrome? Dr. Vanity, you have any questions or a difference in opinion the way we manage?
No, I think I totally agree with you. And what I wanted to ask you is, when do you decide when you want to do a lamellar patch in a dermoid, and when do you decide you would just go ahead and probably a simple shave excision with an AMG would do on these patients? But the depth of the corneal involvement always?
True.
Or,
We do,
yes.
that's an excellent point. We do preoperatively UBM, and if the dermoid, it is occupying less than 1/5 of the corneal volume, then simple excision would actually a good strategy, but invariably you have a small front of conjunctiva which migrate onto that. So that's the only concern.
Yeah, I totally agree with you. Whenever there is a stromal tissue loss, the conjunctiva always crosses over, and a pseudopterygium formation invariably comes. So if you're doing for a cosmetic purposes, even with a patient with 6/6, totally agree with him. I would probably go on a deeper dissection so that you try to give as near possible cosmesis in terms of removal of the opacification in that area.
So we'll move on to the next. So what are we dealing with this one? So it's a type of mucopolysaccharidosis, type 4. He's grossly stunted. Although his cognition, everything is very normal. It's a type 6, MPS. He's a very intelligent boy, and currently he's doing 10th standard and recently developed paraplegia, unfortunately. And sometimes, these conditions mimic several other entity. It could be PCG, CHED. Invariably people get confused. What is typical about this one? You have a normal white to white diameter. There is no limbal stretching, no blue sclera, and you can typically see a granular opacification of your cornea. It is uniform, limbus to limbus. You don't have any bullae, unlike in a CHED. So it's not an endothelial disorder. It's only abnormal accumulation of your glycosaminoglycan in the corneal stroma. So this can be easily tackled with again lamellar surgery. One of the reason is also, again, most anesthetists are reluctant to intubate these cases. One of the fact that your entire nasopharynx, oropharynx have completely stenose because of abnormal deposition of aminoglycans. They also have a very large protruding tongue that also difficult for intubation. Unless you have a very experienced, well-versed anesthetist, and these are the cases are extremely difficult. Even their chest doesn't expand. So herein what I'm trying to do is trying to remove about 60 to 70% of the stroma. Then you can go and attempt, you can also do the hydrodelamination or a viscodelamination. One of the reason is invariably your big bubble will be unsuccessful. Fact of the matter is, this glycosaminoglycans actually deposits within the corneal lamellae, so the air doesn't percolate. So you can't have a successful big bubble in these cases, and a manual dissection is the way to go. In most instances, I opt for a pre-desmetic DOLC in these cases. They typically give extremely good results in these cases. And eventually, endothelium supposed to get involved in these cases too. So at least for a fourth decade, endothelium should function, because it's a life-limiting disease. As you know, most MPS, they do not survive beyond third or a fourth decade. So here I'm attempting an OVD bubble where I'm using a high visco Helon 5. You can actually see this is an expanding perimeter of the OVD bubble. Unlike in a air bubble, so wherever you inject, it'll the bubble start expanding. It doesn't percolate the stromal lamellae. So if you have an access to the OCT, you can do an intraoperative OCT. So the way I go is fill the chamber with air, identify your triple reflex. So then start expanding. This is the visco bubble, and this is a perimeter. And you can actually also see in a OCT, you have almost nearly close to the Descemet's membrane. So it gives an extremely good results. And cases where you do not end up achieving such a good OVD bubble, you have entire opacification. So again, you have to go by layer, and the residual you can reattempt your visco bubble, and you can bear the Descemet's membrane very safely. And these cases, they tend to do extremely well post-operatively, and they do have a higher tendency for hyperopia. They may have an optic disc abnormality, and this has to be managed with a multisystemic, including pediatrician, neurologists, to tackle these cases. They have a useful vision. We did do a specular microscopy in these particular cases, but one of the criticism, the endothelium eventually get involved in these cases too. So at least for a 10 or a 20 long years, this graft should do well in these cases. Quickly moving on to the other entity, this corneal keloid. You have a very wide gelatinous elevated lesion on the corneal surface. At times your vascular component may be much more severe. We could label it as a fibrous pannus because it's a components of vessels and fibrous tissue. Quickly getting into this videos. I'm just trying to excise this gelatinous lesion. So once you do excision of that one, you can go ahead with a regular technique of doing a big bubble DOLC, and it's pretty easy. So you can have without any complication or perforations. Again, in a fibrous pannus, one of the things is you can't attempt a big bubble directly. The reason is a visibility. Once you have a visibility, and it is a fairly easier. What is this? A large tumor-like thing on the cornea. So all around limbus is paid. Any guesses? So this is a classic corneal dermite. So it's confining to the cornea. So once you excise in toto, you can go with a manual dissection. And here if you see, my needle has gone inside. See? Oops, here has gone inside. So don't worry, you don't have to convert this one. So I removed layer by layer, attempted. This is called hydrodelamination technique. So you can see the fluid wave. Even in those cases, if you have inadvertently entered anterior chamber, you can still proceed, and we have very good DALK on those cases. Just to highlight that one more case, my technique of hydrodelamination. So it will expand similar to the air bubble. Although it doesn't actually identify a predesmatic plane, and it is very safer, you will never end up having a perforation. You can't achieve a type 2 bubble, at least in a pediatric age group. So you can actually, bear the desmids here. See, it's a pristine clear. You can still go ahead and have a safe DALK in these cases. This was a child, who had this lime soap retained for many years. Sorry, this video is not running. For nearly 7 years. And it is not only affecting his vision and also cosmesis, and used FM2 DALK in these cases, and he has completed about 3 years follow-up. Despite this lime block retained for 7 long years, his underlying endothelium were absolutely fine. So you still can have a good results in these cases. All I had to do in this particular case, you have to shift your bed and try include part of the limbus, lower limbus, to get that result. So OCT shows, although the cornea is much thicker, so the child is doing well with this. So I deliberately put a thick tissue. The reason is subsequently I can go and do an enhancement in the form of PRK, even if I end up having a significant astigmatism. And these are the entirety we particularly see in India. So where you have a classic stickler-like facie, blue sclera, and a large keratoglobus. And a published report shows by 10th year, most of them, they lose both the eyes. Because the trauma is one of the most lethal, the sight-threatening cause in most cases, even a simple trivial trauma. So good peritomy. I'm very meticulously removing epithelium because it's epikeratoplasty. I don't want any epithelium in the interface, and results in epithelial ingrowth or opacification subsequently. So the second step is creating groove all around. And the third, you need to fashion your graft, and you can tuck in. It's basically tuck in keratoplasty. So your harvested limbus can now, by using fibrin glue and a Vicryl, you can just anchor at the artificial limbus you formed, and that results in a good outcome. You can actually see an extremely thin cornea. Now we've added tissues. There's a OCT. So thereby, you can actually prolong the sight loss in these children, even if they have a one eye with a 20/100 or a 20/800 vision. That's really useful in the children's. So he's been maintaining well with this and has a very decent corneal thickness, and it will make immune for them to get injured or a eyeball rupture. And a variety of the HSV cases, this can also be tackled with a simple lamellar transplantation, unlike PK. This was a child was referred from Dubai, and who had unfortunately contact-related contact lens acanthamoeba keratitis for 6 long months, and we have to consider that child for a DALK. So once you dissect the opaque infective part, then the rest of the techniques are similar. You can try achieve a big bubble in these cases too. So I'm attempting a big bubble. It became partial bubble. Then I have to use a combination of Helan to get the bubble expanded. And so it's one of the keys here. We have to bear the desmids here. If you leave behind a residual stroma, they may be retaining your acanthamoeba cyst. So once you start steroids postoperatively, they recur. So the key is we have to get the desmids bearing DALK in all acanthamoeba cases, if at all we are resorting to the transplantation. Considering this child had all toxic medications, infection for 6 months, postoperatively cornea took a while for a complete recovery. You can see as if it is a stromal keratitis. So this child has finished nearly 10 years, doing a very nice, and his myopia is matching with other eye. And DALK can be a good option in acanthamoeba keratitis. So DALK has several advantages, but one of the things which we need to keep in mind, again in terms of suture related infection which is similar to the PK. So other thing, we can actually switch up steroid maybe by year and a half based on your residual or a host bed. So the doll can be a very successful tool, can be used in a most anterior segment, the problems which are confining to the stroma. Now quickly move on to CHED and a PPMD. It comes as a different spectrum, and you can actually see a exuberant fibrovascular degenerative pannus. These cases may not be a good cases for a DSEC. So also a technical difficulty is the stripping Descemet's membrane. Normal Descemet is around 15 micron here. It may be as thicker as 50 microns. So it's difficult to remove in toto. It will invariably end up having a piecemeal kind of a dissection. And in the process we may hurt lens or even a uveal tissue. So thereby we made a certain modifications. Now what we do is we do not strip Descemet's membrane in these cases. I can use a various technique like pull-in, push-in technique. And this technique, you need a lot of instrument maneuverability and AC maintainer. It's very important to get the centration and also remove all the wrinkles from the graft. This is a very simple technique we started doing and have a good experience in this non-Descemet stripping endothelial keratoplasty. So so all wounds have to be sutured in a pediatric age group. So I'm just maintaining, the mobile bubble if I do not do any peripheral iridectomy to minimize the risk of pupillary block in these cases. So we went ahead and did even our objective assessment to see the corneal transparency, how much it improves. You can see in a pre and a post-operative, there is a significant improvement in the corneal transparency. So we did also a lot of morphometric studies here. Eventually the host and graft actually thins out. So there is a gradual myopic shift. This is a one patient, both the eyes. So in a 6 months period, you can see a significant restoration of the corneal opacification. So in order to just to compare, this is following a PK, you have a pristine graft. So one of the demerits of DSEC is always people when you compare with regular cornea, so you would say that it is not as pristine as a graft. Although we did a paid eye comparison where children, although the DSEC eye had a little hazy cornea, but they did prefer the DSEC eye. One of the fact that it had a least astigmatism, no sutures, and surface was much more stable than the one eye which had a graft. Again, this is a morphometric and densitometric data. There is a significant reduction. So the entire thing, I try to put it in a one mathematical table. So by 6 months, indeed, your corneal transparency improves. You can actually get a very decent refraction, and your astigmatism under 2 in a pediatric age group following a transplantation, that's the biggest boon. You can rehabilitate them much faster. And you can also see the host tissue from 1000 micron a median to it has come down significantly more than 45% reduction in the host. That explains the myopic shift, whereas the graft is almost stable throughout, and mean densitometry has come down significantly. The normal mean densitometry of a normal cornea is around 24. It is almost very close to normal cornea, although it is not as pristine as a graft. So the general rule what we propose is in any CHED wherein you can actually see the iris details or pupillary details, you can actually resort to the DSEC and DSEC. Wherein you can't see the AC details or iris detail, it would be prudent to consider them for a PK, as I showed the initial picture where you have an exuberant degenerative pannus. So even if you excise that pannus, you have a significant scarring that may actually preclude the ultimate visual success in those cases. So the DSEC can be a good option here. It's a very simple, and NDSEC is cuts the time, and it's a superior surgical alternative to PK. However, you do have a, although in terms of allograft projection is 10 times lesser than a PK, but you need to keep them on a post-operative steroids and explain this risk, and you can expect a rejection. This is a lifetime risk. So appropriate case selection, so wherein you have their Cornea is much clearer, wherein it allows you to see the iris detail. That's one of the guideline. Meticulous surgical steps, good post-operative follow-up, and a prompt amblyopia therapy. We can start as early as 3 weeks in these cases, so that will help us achieve a good results. Thanks for your kind attention, and do note this particular dates, high-end systemic disease. We have one of the small symposium. It's a very interesting one. If there are any questions, I'll be happy to answer. Before I invite my next speaker, Dr. Vanati, she will be speaking on a pediatric keratoplasty overview.
Sir, may I know what is the post-operative steroid frequency that you would use?
Excellent question. In children, what we do is I start with 10 times. That's easy to remember and note. And every month we drop 1 time, meaning second month 9 times, third month 8 times. So for the 10 months of very aggressive steroid, from 10th month onwards, it is a 1 time. If there were to be any rejection in between, so we had the baseline 1 + 1. If somebody had some cataract surgery or AGV, then you have to take each one as an event. You add that to the baseline. So it may be 3 times, 2 times, or a 1 time is the baseline. So then I continue the steroids for the next 18 months, and thereafter you can actually make it alternate day or twice weekly based on parents' complaints. Dr. Vanati, you have any difference in opinion?
What I wanted to ask you was, how do you vary your steroids when your children are going to have an immunization? Do you totally take them off the immunization schedule
True.
for 6 months?
True.
I find it a particular problem because in my practice scenario, they are all below poverty children. So I think the benefit of taking them off, the risk of taking them off an immunization is more grave than the risk of a graft rejection. Perhaps you don't see that as much as I do. So what is your approach on that?
Absolutely. So I told them, just for the next 6 months, particularly live vaccine, an absolute contraindication, right? So they just trigger and knock off your graft like that. Even if you make it every hourly steroid before vaccination.
I see it doesn't work even, stepping up steroids or giving oral steroids. It doesn't really work, and you find them within a matter of within the next UA, they just come back with a white graft. It's a hyperacute rejection, and you cannot do anything about it.
True.
Okay.
That's excellent point, right? Thank you.
Thank you, Murali, for the opportunity to again be part of your wonderful course, and I think it's been wonderful interaction with you and your team, and I have learned more, and I think it's been a fantastic experience, and thank you all for being with us. For the next 10 minutes, I'll just take you through an overview of pediatric keratoplasty, mostly tailored towards an Indian scenario. This is not an exhaustive talk, but I try to completely cover as much as possible in given the period. So when we look at pediatric keratoplasty, the particular concerns which you have to deal with is looking at the varying indications, how the preoperative considerations differ in pediatric keratoplasty as related to adult keratoplasty, the surgical considerations or the intraoperative considerations which you have to look at when you're dealing with pediatric corneal grafting surgeries. And you probably will put into use alternatives to penetrating keratoplasty to a higher extent than you would do it in adult keratoplasties. What are the challenging scenarios where you know that you need to be technically more sound when you're doing these cases? And what are those cases where you probably have to step back and say, okay, I'm not going to do a graft in this particular eye? And of course, post-operative considerations we've already heard from Murli just before here. The indications of pediatric keratoplasty is now probably changed, and it has been reclassified into how you look at here as congenital corneal opacities which are shed, and congenital corneal non-shed opacities. You look at traumatic and acquired non-traumatic. The shift in classifying the corneal morbidities now is because you're looking at it based upon the prognostic factors once you have done grafting procedures for these, and the prognosis varies differently for most of these children. So there is an review and survey ophthalmology, and of course it's a little outdated, and we're working on updating literature on this particular aspect, but it does give you a comprehensive overview of all the particular concerns with pediatric keratoplasty, both in the all in the preoperative, intraoperative, and postoperative phase as well. Just in a nutshell, what are the things which you would probably consider differently in corneal grafting in children is the use of Fleringa rings. Basically, I do not use most of Fleringas in most of the pediatric eyes, but yes, it is always advisable to go and start your surgery with the Fleringa rings. Your central marking needs to be accurate. You need to be surgically decrease your all factors which would cause a post-PK astigmatism, because managing post-PK astigmatism in children it's more difficult than you would do in adult cases. Most of these children are probably not going to be telling you how well or how bad they are seeing. It's really not going to be possible to go ahead and do selective suture removals in these particular cases. So your surgical technique needs to be perfect so that you're giving them that amount of visual rehabilitation for amblyopia management without the need of glasses. So it is a very, very challenging scenario, and several times a well done surgery perhaps is not the end point for these children. Choosing the appropriate refined size again all goes in with your surgical technique. And when you're dealing with corneoiridic scars in pediatric cases, especially post-keratomalacia, post-infectious keratitis scenarios, they might be badly plastered on, and you might have to use a technique variation of layer by layer delamination, trying to preserve as much of iris tissue you can for these patients, and trying not to injure the lens most of the times, because going in for a lens surgery in this grave scenario is not going to be a win-win situation most of the time. So that's another concept which you need to look at in these patients. A peripheral iridectomy, again, you probably would consider in corneal grafting surgeries in children, because especially in extensive corneoiridic scars, because you do not know how much of the angle is probably decompensated in these patients. A good optimal preoperative evaluation is probably very important to your postoperative or intraoperative planning as well. So if you have an access to an intraoperative UBM, it really adds on to your planning, and where you are, you would know where to enter, put your first MVR blade entry. If your angle is completely closed, you need to put in an implant for these children, and where you would place your implant. A good examination under anesthesia to record and monitor all the preoperative biometric measurements of the eye, IOP measurements, and also for the timing of the surgery and the need for surgery. So I think the secret lies in a very meticulous preoperative evaluation in children. I think when you now move on to indications, and when you're looking at CHED corneal opacities, congenital corneal opacity, CHED related, and Murli has shown you wonderful videos earlier, and I think we are now moving to looking at reclassifying CHED, and CHED 1 no longer exists, and so only CHED 2 is now, which is conservatively called as CHED. And probably when you look at CHED 2, which is earlier the autosomal recessive CHED, the opacification is much more in most of these patients, and perhaps they are not amenable to do a good to do a DSEK procedure or endothelial keratoplasty procedure, and you have to go ahead and do a penetration keratoplasty. Murli has already covered all the aspects of visibility, the variation in technique. These are phakic eyes, they are small eyes. You'll always need to avoid a sutureless DSEK. Suture your wounds even if you get an airtight wound at the end of the surgery. Place your incisions and your maneuvers of instrumentations under the cover of the iris. Use as least toxic substances into the anything what you need to inject into the AC, so that you do not cause a cataract formation in these phakic eyes. And again, with children, positioning them postoperatively several times becomes difficult. I have lost my grafts to poor positioning and to eye rubbing, and had to do a PK subsequently in a well done DSEK in pediatric patients. So there are particular concerns when you are looking at it. This is not to discourage you from taking a decision on doing DSEK in pediatric cases. I think once you are conversed with the technique and you are confident and you have less complications in your adult patients, you're probably ready to move on, provided you know that you have good visibility in these patients. Again, peeling could be a problem, as Murli rightly pointed out, and if you do have, you could use your external illumination, or if you have an intraoperative OCT, it really helps you to pick up. But yes, you could probably again do it without peeling in, as he rightly suggested. We'll then move on to the particular problems of penetrating keratoplasty in CHED patients. Several times you might, once you enter, sometimes you do the Descemet's membrane falls back into the AC, and this is inadvertently missed even by the most experienced, even when you have looked for it. And I've had a couple of instances, and it's really surprising to go and see how you have that double chamber, and the decision of whether to intervene or not to intervene on the double chamber. It's a nice paper which covers extensive literature and also tells you how to intervene when these cases are present. But I invariably do go intervene early in the immediate post-op, and I see them so that I do not want my graft to decompensate, even when I have a communication in the Descemet's to the anterior chamber, and you would like to restore the integrity of remove the retained Descemet's membrane. This is one such case when even after having looked for particularly, and the graft looked perfectly fine his first day post-op, and when I looked at the slit lamp on the patient, I found the double membrane thing. Sometimes you do tend to miss it because children are very uncooperative for examination in the first post-operative phase. I was lucky to pick up immediately, and then on the table, because you don't have the luxury of the optics of a slit lamp, the operating microscopes are never as good as your slit lamp, but then an IOCT really helps you to pick up in these membranes and avoid inadvertent trauma to the iris and the lens, and complete your surgery in a good manner. Today, when we are again looking at non-CHED congenital opacities, these entities of sclerocorneas and Peters anomalies have all been clubbed together under one particular head of anterior segment mesodermal dysgenesis. So there are particular problems that these are anomalous developments of the cornea, of the angle of the limbus, the length of the globe, the associated microcornea. So these are problems, and the limbal stem cells again probably are not well formed. So you could have a gamut of problems when you do keratoplasties in these patients. And I think all of those who are doing pediatric keratoplasty in such an ASMDs, you would say you have a very mixed results in your surgical outcome. I find managing these patients very difficult with a high gamut of persistent epithelial defects because of the limbal stem cell deficiencies. When the graft do well, they develop a glaucoma later on in these patients. So you do have to continuously monitor and follow these patients so that you are able to give them a good follow-up, or at least whatever possible outcome for these patients. When you're doing penetrating keratoplasty, I'm sorry, this video doesn't seem to be coming on, in ophthalmos patients, the concern is these eyes are large, and you are wondering of what size of the graft you have to put in. There is literature here when they say you use the routine 8 millimeters, and there is literature also saying that you use larger in the hope that you would transplant as many endothelial cells as you can, and you're doing a PK for them. Always remember that probably these eyes have undergone filtering surgery procedures in these eyes, and their glaucomas can go out of control following surgery in these patients. And another particular concern is these could be myopic eyes, and you could have subluxated lenses, and there could be cataractous lenses in these patients when you take them up for surgery. So you need to be prepared for multiple interventions. Murli has also already covered keratoplasty in dermoid scenario, so I'll just move away from that and then take you pediatric acquired conioiridic scars or triple procedures. You probably need to look at when you want to do when we want to do a lens surgery as well, and the particular problems, concerns as of choosing the IOL part is going to lie in this scenario as well. Keratoconus, most of us have now shifted on to rehabilitating by non-surgical procedures as far as possible. You do need to do collagen cross-linking for these, so I'm not dealing into those particular concerns, but we are doing lesser and lesser of full thickness keratoplasties and more of deep anterior lamellar keratoplasties for these children. And as Murli showed those nice videos, we are adopting more of TILC procedures, more of inferior crescent lamellar grafts and others. Infectious keratitis is a particular concern in pediatric scenarios, and when you look at infectious keratitis, I strive as hard as possible to heal them medically before you would take them on for surgical. Probably an optical surgical procedure is more is better, and do not take them for therapeutic as long as it could be delayed for these children, because a therapeutic graft heals very fast, sutures loosen very fast even in optical keratoplasty scenarios. Looking at graft host junction, suturing concerns are particular in pediatric cases, especially when it is intubated and your head is not positioned well. Several times the chin tends to be lower than the forehead, and then putting in or suturing the inferior 180 degrees could be difficult for beginners, and you could land up getting a posterior gape like this. And when you see them later on in post-op, this iris tends to come forward and plug this posterior gape and induce a pus formation. That's a particular concern which you would like to deal with in these scenarios. I'll just take a couple of minutes more. Is that
Yeah,
okay?
you have 8 minutes. You can
Okay.
go ahead. 8 more minutes.
8 more minutes. Okay. So these are again challenging scenarios when you are looking at conditions such as this. These children are almost near blind children, and you will find the parents coming over to. I think there's a problem in getting all the videos running. It was working. Okay. So what you did briefly see earlier was the ocular digital phenomena in these children, and when you see such children in the I really don't defer doing pediatric keratoplasties for them, and they are really probably don't have much of a visual prognosis. Some of them do go ahead and do mercy attempts, but they tend to keep on poking their eyes, and they are very high risk cases for graft dehiscence later on, and you're going to need an emergency GA interventions earlier. Chemical injuries in children, particularly Indian scenario. In the North Indian scenario, children playing with tuna packets, tuna which is used for pan, and you have the splash of concentrated tuna onto the face and eyes, and landing up with severe ocular surface injuries. Again, need to be dealt in sequential manners of looking at the acute chemical injury scenarios, and then subsequently following them up with limbal stem cell rehabilitation or transplantation procedures, and then wait and take them on in the next 3 months after you have reconstructed the ocular surface with simple limbal epithelial transplantation to look at lamellar procedures to give whatever visual rehabilitation or optical rehabilitation for these children. Again, you have children like these which are normally tend to get classified as anterior staphylomas, but if you take them up under UV and you see that they could be corneal dermoids as well. Do go ahead and do tectonic grafts for these children because the lid does not close, but by and large visual prognosis for such cases is not really good. Then comes in the entire scenario where you have to touch the eye or not touch the eye. So when you have to look at here as congenital corneal anesthesia syndromes, the heretosensory autonomic neuropathy eyes, there is a whole gamut of disease of grading in these diseases where you have a severe corneal anesthesias, and it's probably wise not to touch these eyes to do corneal grafting surgery and heal them with conservative methods and give them as much of optical rehabilitation as you can for these eyes. So this is the various classifications and which go on for HSANs and the subsequent clinical features which you have, and it's always wise to be aware of this. Several times these children, remember, will present to the ophthalmologist as an infectious keratitis patient and would probably get missed, and unless you're going to closely look at for the systemic features, sometimes the history the parents give, which makes it very easy to pick it out from the general population. Another particular scenario when you're looking at dealing with families below the poverty line or with poor weaning practices, you have keratomalacia, which still does exist in the Indian scenario. Severe protein energy malnutrition children coming with acute corneal melts and with poor prognosis for thriving as well. Trying to take these children out of this severe corneal morbidity is a challenge for most surgeons, and you'll probably have to work closely with your pediatrician. Remember to give them vitamin A dosage along with multivitamins when you're dealing with them. Always remember what is the correct dosage, because you could also cause hypervitaminosis, which causes a benign intracranial hypertension, and you will find the child crying incessantly in the night on the day you have given with vitamin A, and a BIH could decompensate your optic nerve irreversibly, and you will lose the child's vision to a treatment which initiated in a manner which was probably not optimal. So I always find it relevant to talk to my pediatrician as soon as possible and send them over to calculate the vitamin A doses, because most of these children are in bad systemic states and also need a pediatric interventions for nutritional advice and for systemic therapy to take them out of the PEM scenarios as well. They do have associated secondary keratitis, secondary infections, so managing pediatric of the corneal infections and probably taking them on for an early therapeutic or tectonic graft and following it up by an optical procedure is going to be mandatory, or is going to be necessitated when especially both eyes are lost for these children. These are particularly grave scenarios. The results are not very great when you do keratoplasty for keratomalacias. So, but by and large, when probably the scenario is not that bad, then you could think about contact lens rehabilitation, optical iridectomies, and rotational autokeratoplasties. So this is a condition where you'll probably like to put to use the alternatives to penetrating keratoplasties. Most of these children could be one-eyed children who have come out of their morbidity, both systemic and ocular. And when you see cases like this, you probably can look at alternatives to visually rehabilitate them. A word of caution when you're doing rotational autokeratoplasties: always rule out that it's not been a viral infection, because rotational autokeratoplasties don't do so well in viral etiologies. But if you're looking at post-traumatic corneohydric scars or post-keratomalacia corneohydric scars, then you have to plan your surgery well of how you're going to rotate. But remember, there is no margin for error when you're trephining. You're going to use a same sized graft to close on to the recipient window, so you need to be perfect in your suturing technique, and when you're doing your trephining and when you're cutting out the host tissue. And two is, you're going to have a higher amount of residual corneal astigmatism in these cases. Three is, you have to your technique needs to be perfect so you do not cause any lens injury and add on to the morbidity in these cases. Earlier, people were not doing rotational autokeratoplasties for corneoiridic adhesions and were simply placing it for corneal opacities, but then a wise case selection can help you to rehabilitate these children with a 660 or a 624 without the need of glasses, and they could go on without the need for a penetrating keratoplasty. Again, I think Murli showed you lovely videos on lamellar procedures and the difficult scenarios in lamellar procedures. This is just to complete the picture and show you this is a pediatric DALC for an advanced keratoconus, a young child in whom I just have the IOCT to show you the picture. You find the bubble which is just dissecting beautifully. This is a D DALC, or what's a desmetic DALC, and you've seen the bubble forming here beautifully and captured on the IOCT as well in the right plane. It helps to see you, and this is when you do the brave slash, you just watch carefully, you will find the desmets falling back into position once you release the air out of the big bubble chamber. So just to complete, and I think Murli already touched upon all the nuances of lamellar grafting surgery in children. When you look at doing manual DALCs for post-chemical injuries, that's a difficult scenario, a totally different scenario, because you'll never be able to achieve big bubble DALC in these patients. And the manual layer by layer dissection is probably going to work out better for these. You also remember that these are scarred cornea, scarred ocular surfaces. The surfaces have been reconstructed with amniotic membranes, with SLET procedures, and the cornea is thin and opaque in most cases. So you do not have you cannot afford the luxury as you would do a manual DALC in clear corneas as in keratoconus. You have to be very careful. They have a high chance of perforation in these cases, and the corneas could be thin in several places as well. And so this is a more challenging scenario as compared to a DALC in a keratoconus. So where you need to remember is a higher chance of perforation. Use manual layer by layer. So you need to have perfected your lamellar techniques before you shift on to this procedure in pediatric eyes. Again, watch out for postoperative epithelialization. Look at the need for immunosuppressant therapy. We really don't know how long these grafts are going to survive, because I have particular concerns of raised postoperative graft infections in these particular patients, and if possible consider alternatives to therapy. Again, a post-SLET DALC, this is a post-keratoconus DALC in a pediatric eye. This is a post-SLET DALC in a pediatric eye. Not all cases land up with such wonderful results. I've had bad results as well in some of the cases, and this paper talks about our experience of outcomes of SLET and DALC in post-SLET eye. So I think I'll just skip most of the literature out here and go on to the challenges here. Remember, these are small globes. They have reduced scleral rigidity. They have high positive vitreous pressure. You need a good anesthetist to keep the eye soft during your surgery, and optimal preoperative planning is very imperative. Postoperatively, the need for repeated examination and anesthesia. This is a particular point you need to counsel the parents before you take these children on for surgery. And if they are not willing for a regular follow-up and for subjecting the child for repeated examinations and anesthesia, please don't take on these cases. You might have higher increased inflammation, but it's not a particular concern these days, given that our techniques have evolved to much higher levels these days. But yes, secondary glaucoma and immune graft rejections and infections are huge concerns in our scenarios. Something which I'm always bothered is rapid suture loosening, and you might have sutures loosening on consecutive visits as well, and even as early as the third week or the second week, and you probably would want to go ahead and replace these sutures when they loosen within a month. You would consider early suture removals probably even at 3 months in these patients because of the high risk of suture-induced infections in these patients as well. The challenge is to network well with your pediatric ophthalmologist and to visually rehabilitate these children so that a well done surgery translates into a good visual outcome is when you probably succeeded in managing corneal grafts in children. The particular goal is establish your diagnosis, establish and look for other corneal morbidities you have in these children, determine the visual potential this child is going to get, and the amblyopia management, plan it preoperatively. The comorbidities need to be optimally managed both preoperatively and postoperatively, and pair up well with your pediatric ophthalmologist for good outcomes. How has pediatric keratoplasty evolved today is, are we strong enough to do glaucoma drainage devices for these children along with our as a primary procedure? Most of us still don't, and we do it as sequential procedures, but the West is probably moving towards it. I think there are a lot of latest literature which is coming out with saying that pediatric K-pros are not safe. Even in those people who are doing it probably would refrain from doing keratoprosthesis for pediatric. And of course, yes, there is a shift towards doing higher and higher amount of lamellar procedures in these children. But remember, when you're moving on or you're a beginner, it's always best to be cautious and do it once you know that your complications have been lesser in your adult patients, and you can achieve better outcomes in your pediatric patients. When you are sure about it, then you shift on to lamellar procedures in children. These are the particular concerns when you're looking at pediatric grafting, graft infection, glaucoma, astigmatism, and an integrated treatment approach is usually not possible to get all these together. So if you are able to manage all these, then perhaps I think your results would be fantastic. But I'm really sorry, I don't know why all my videos are not running. So this is a particular case of a post-lead talc who went on to gain a vision of about 660 to 624 and subsequently kept repeating with repeated graft melts. I've almost done three graft exchanges for this child, and now given up. She seems to be coming back with repeated ocular surface melts and secondary infections, and that's a particular concern which I see in these post-talc scenarios. So it's always not a story of success. It's a very mixed response when you do pediatric keratoplasties, but be geared up to tackle the challenge. Thank you for your patient hearing.
Thank you, Dr. Vanati. That's very comprehensively she has covered everything about pediatric transplantation. If there are any questions for Dr. Vanati? Call upon next Dr. Somashila. She would be talking on a surgical management of allergic eye disease in pediatric age group.
Very good afternoon, and I would like to really thank Murli for including me in your instruction course. Both of us, we practice at LV Prasad, Hyderabad, and Murli is basically the one who has the huge load of pediatric patients. I manage the ocular allergy, so I do see pediatric patients, but not to the extent that he does. And he has, though he speaks so calmly, he's actually very passionate about his patients, and he takes such good care of them. So we are very grateful that he's part of our team over there. So my presentation is very brief. I hope to just give you a few tips of surgery in pediatric patients who come in with allergic eye disease. As you know that we have vernal keratoconjunctivitis and atopic keratoconjunctivitis, which are the more chronic allergic eye disease, and they usually affect patients in the pediatric age group. So unfortunately, it is not self-limiting, though we keep telling the parents that they will, at least for VKC, they will, as they grow up, they'll sort of have a remission. But sometimes it progresses in adulthood also. So when all should do we look at when we need to do surgical modalities for these patients? So the top few indications would be in cases of giant papillary conjunctivitis, and especially where it's causing a shield ulcer. We also need to do surgery in cases of steroid-induced cataract and steroid-induced glaucoma if it's not controlled medically. And as Vanati had talked about keratoconus in children, we also have patients who have VKC and keratoconus because it's very often associated with each other. And then the rarer cases would be in cases of limbal stem cell deficiency secondary to chronic allergy and cases of microbial keratitis. So coming to the first indication, what do you do for patients with giant papillary conjunctivitis? So I'm sure that all of you in practice have seen these patients with extensive allergy and this massive cobblestone papillae. So these papillae, both mechanically and due to the toxins that are secreted, cause repeated shield ulcers also in these patients. And of course, the patient is extremely symptomatic due to the allergy, keeps on rubbing the eye, loses days of schooling, and so on. So the best modality to take care of this problem to take care of the allergy is to give a supratarsal steroid injection. You don't have to do surgical excision for this papillae, you just have to quieten the allergy. Don't do simple excision. I'm just put these down because they've been described in literature. People have done cryoablation. All of these aggravate the allergy. Some people have applied amniotic membrane. Maybe I would be okay with just applying the membrane without excising it. Some people have tried MMC and 5-FU in very recalcitrant cases. The results are not very, very encouraging. So I've put the list down there only to discourage in general to do anything about it. The best case is that to go ahead and do a supratarsal steroid injection to take care of the allergy. How do we do it? Can use a simple 26 or 27 gauge needle. We need to take the patient if it's very small, and of course most of the time under anesthesia, and fold the upper eyelid, and there is a space where the tarsus muscle ends, so you need to find that potential space. You can choose the drug based on how much you think that you're going to have compliance from the patient and the parents. So are you able to measure the intraocular pressure? So I like to go with methylprednisolone in those patients where I'm not very sure that they're going to follow up, because methylprednisolone is short acting. It may last for about 20 days or so, and the pressure rise is not as high. Whereas if I have patients who are very reliable and I know they'll come for follow-up, I can measure the intraocular pressure. I would use triamcinolone, which is a longer acting steroid. So what happens is you give the steroid injection, there's dramatic results. By the next morning itself, the child is usually comfortable. Of course, monitor the IOP, and you can repeat it. Maybe 6 months later, the next time allergy season comes up, the child comes back to you again with this kind of problem. It is reasonably safe as long as you follow the guidelines that you need to do. So here's a short surgical video which will show you the same thing. So this is under anesthesia. We're using the surgical microscope. Already folded the lid. It's a very tight space, so which is a good thing. You can't get too much of the drug inside. You raise a wheel over there and just find the place and raise a wheel over there. You can inject very comfortably about 0.5. I think that is more than enough. You can inject less also. You don't need to inject any more than that. And just massage that area till you can spread some of the drug reasonably well. Sometimes you have to do more than one puncture because you can't find the site. And here you tried from one location, you couldn't find any space, so you can try it from the other location. And you can use 2 and 3 injection pricks because it is under anesthesia, and just inject the drug, and that's it. So it's a very simple technique here. Most of the drug is going subconjunctival. Some of it is going supratarsal, where actually the papillae are, to address the problem of the papillae. The only instance where I've had done something like an excision for the papillae was this particular young man. He's 16 years old, and you can see that his papillae are not only huge, but they're also, some of them are keratinized, there's squamous metaplasia, and they have keratin on the surface. So every time he has active allergy, it causes a shield ulcer. And the problem for him is he's already missed a year. He's giving his board exams when he came to me this time. And I decided that if I just give him a supratarsal injection, again the mechanical rubbing will still lead to the shield ulcer. So I gently debrided this area, the keratin of the surface, and gently excised the papillae that were corresponding to that shield ulcer area, and applied an amniotic membrane on top, and of course gave a supratarsal injection, used topical steroids post-op. And this patient did pretty well. He's not, at least he could give his exam, and now he may come in next year again with severe allergy, but we could tide over the crisis of his not being able to function well. So these are some of the literature showing that there's a lot of recurrence, obviously, if you do simple surgical excision. But so the papillae just come back. But more important is that even the allergy becomes a little bit more severe. So I would suggest that don't just excise. The next instance where you need to use the blade, the surgical blade, would be in cases of shield ulcer. If it's a stage 1 or 1A where you have almost a translucent base, so you don't need to do anything except to sort of, this is quite a large one, so you need to just debride the surface, debride the edges and apply a bandage contact lens and use topical steroids. But if you have a plaque like this or like this very elevated plaque stage 3 kind of ulcer, then you have to do a superficial keratectomy, otherwise the underlying epithelium won't heal. So you have to excise this entire plaque in toto, and either you can put an amniotic membrane if you have access to amniotic membrane, or you can leave it bare and use a bandage contact lens and topical steroids. So this will resolve very well. The advanced grades, you have to do surgical removal. This is another patient who, in addition to having a huge shield ulcer, also had, you can see these multiple infiltrates, unhealthy looking, and they're beyond the area of the shield ulcer. So this patient, at the time of, we debrided the edges and also sent the material for corneal scraping to microbiology. This is the papillae associated with the shield ulcer, and it turned out to be bacterial in origin. So we could use broad spectrum and fortified antibiotics and decrease the infection. Later on, there was, of course, significant scarring for this child. So we published the results of how we manage shield ulcers, and what we noticed is that those cases where the shield ulcers were larger, we used amniotic membrane, and our clinical impression is that the healing time was more rapid in these patients. But I guess that if you have small ulcers, you don't need to use amniotic membrane. Another study that we published is that we picked up a large cohort of patients, 468 patients, and we looked at various problems that they could have. And what we noticed is the problems which are sight-threatening included keratoconus. That's not really a complication of VKC, but it's an association perhaps. So 6% patients had keratoconus, 6% had steroid-induced cataract, and another 4% had glaucoma, steroid-induced. And other minor complications were corneal scar formation, we had dry eye, and associated ptosis, but we also had cases of microbial keratitis and stem cell deficiency in a few patients. So luckily, microbial keratitis is extremely rare, although many patients come with shield ulcer. So we need not, we should be vigilant, but it's not a very high complication. So coming lastly to the topic of VKC with keratoconus, it's a very challenging subject here because the child keeps rubbing the eye due to the allergy, and we know that eye rubbing is associated with ectasia. So clearly the eye rubbing and will be instrumental in progression of the keratoconus. Therefore, there's no point in waiting and trying and documenting that there is an advancement in the keratoconus. I personally believe that we should just do an early collagen cross-linking, but we should manage the allergy first, because otherwise the child will keep rubbing the eye. You're not sorted out the problem. What about cross-linking? Post cross-linking, we can expect to have increased haze, and we can expect to have higher chances as well as faster failure, in the sense that we've had examples of children where we've done cross-linking with VKC, and in a year or two again we could document that there is progression. So there's higher chance that it may not succeed and we need to explain to the parents, because they often think that the procedure is one time and why are we saying that you have to do it again. The other thing about cross-linking is that the epithelium may be slow to heal, because there's a large cone, and the tip of the cone has epithelium, which takes a longer time to grow over it, and you put a bandage contact lens. So sometimes all of these factors put together, the tip of that cone will have longer time for the epithelium to get replaced, so you should be careful about that as well. In VKC and keratoconus, sometimes you have to resort to desmetopexy, and of course, as DALC and corneal transplant was beautifully presented by the previous speakers. So these children not only present with earlier advanced disease, they also have huge keratoconus, and they can have asymmetrical. So one eye could be okay, the other eye can have very advanced. So there's a child with advanced keratoconus in one eye and a high drops in the other eye at the time of presentation to us. So one eye is beyond the stage of cross-linking, the cornea is too thin, the other eye is already in high drops. So it's kind of challenging to manage these kind of children. So this is another case which presented to us with high drops, and in addition to everything else that's going on, the child also has Down syndrome. So the compliance of a graft in such children is also going to be not very great. So we decided to first of all take care of the eye drops in one eye and then do cross-linking for the other eye. So for the eye drops, what do? We, as a group, some of us, we do intracameral injection of either air or C3F8 to try and give a tamponade to the ruptured Descemet's membrane. So there'll be some formation of a sort of a pseudomembrane or growth of tissue there. And again, that'll make the cornea compact. So this is what we plan for this patient, a descemetopexy. So, but you can see that after the first intervention, the eye drops is just the same because the Descemet's gap has not closed at all. So there's a huge amount of fluid. As in, this is the ASOCT. This is before surgery. You can see that you can't really see any Descemet's membrane in the back. You can see some here in the corner, but here is just retracted and it's curled itself like this on the edges. So there's huge fluid clefts into the stroma. And day 4, this is after injection. You can really, there is some maybe gas bubble here, but the clefts are just the same. And then day 14, clearly it's not working. It's almost the same as day pre-operative picture. There's a lot of fluid. So what should we do? How do we rehabilitate this patient? Do we just wait and expect the edema to keep going down? We thought we can give a second try, and what we did is borrowed all the techniques from our DSEC. And here, in this case, we first simply injected air into the AC and then did venting incision, the same that we do for, say, a DSEC lenticle. And you can see the fluid getting expressed out. So be very careful because the cornea is very thin. And we gently massaged out the fluid from the clefts. And again, exchanged the air with C3F8 and did a surgical PI also. So this actually worked, and it worked extremely well. So this is by 1 month after the second injection. You can see that's a nice consolidated scar. The cornea is extremely compact, and this is an OCT picture showing there's no fluid. And the best part is that the child could see 20/60 with glasses in this eye, and the other eye we did cross-linking, so we didn't have to resort to any other surgical procedure. It was, I think, reasonably adequate vision for the child to function. So LSCD is a rare complication. We have published results of using SLET as well as CLET, meaning cultivated limbal epithelial cells, and simple limbal epithelial transplant for these patients, which are a small handful that we have, with good results. But again, the allergy has to be controlled. There's nothing different in steroid-induced glauc cataract. You can operate it similar to how we do most of our cataracts, but of course the PCO rates will be much higher, and the IOL power calculation would be challenging if it's a younger patient or the patient also has keratoconus. In glaucoma, they are kind of difficult to manage because the allergy, what do you use? It's steroid response. So you have to use topical cyclosporin or tacrolimus. Rarely, sometimes we use oral steroids or some other immunomodulatory agent like, say, cyclosporin orally or methotrexate orally. And you have to do glaucoma filtration surgery with its higher chances of failure in these pediatric patients. So that's all I had. Thank you.
Thank you, Dr. Somashila. That's an excellent talk. It's covering almost all aspects of allergy-related complications and its management. Any questions to Dr. Somashila?
We must thank people to stay back last day, last show.
Your experience on a steroid sparing medication, something
Yes.
like of
Yeah.
late we've been using a tacrolimus,
Yes.
cyclosporin. If you can allude on to that.
So for many of these children where you know that the allergy you have to control for a long time, so I immediately switched them on to tacrolimus eye ointment that has been working really well. Earlier I used to use cyclosporin for the same reason as non-steroidal sort of a maintenance, but I've just switched on to tacrolimus and I find it works better in my hands. For those extreme cases with a lot of papillae and those giant cases that you saw, giant papillae, for those cases sometimes just using tacrolimus is also not enough. And if they are steroid responders, then I don't use topical steroids. Instead, I use oral immunomodulators for a short while, in short bursts. And in those who are not steroid responders, compliant to follow up, I can check the pressure. I usually use soft steroids. So some of these patients are maybe on 1 drop a day for a while so that they can perform well in school. So we have to understand that this allergy is so severe for them that the child doesn't perform well in school, doesn't go to school. The parents may not understand what's happening, and you have to judiciously, of course, but you have to use the best medication you can to control it.
Dr. Somashila, Do you use tacrolimus over the lids for most of these children when their ocular surfaces are that
Yeah.
bad because of chronic VKC?
Right.
Yeah.
Yeah. So the eye ointment comes in two formulations. One is for skin application. So that one I advise them to use on top of the upper eyelid, and especially in those cases where they have giant papillary kind of response, those cobblestones and all, that seems to work better. So it does go down through the skin. And in the second instance, we have another preparation by Oralab, which, although they don't mention it as eye ointment, but it can be used inside the mucous membrane, inside the eye. So I advise that is more useful for the limbal form, where you see the honor trantas dots and those kind of cases. So both, based on what kind of case I have, I would use one or the other, and I think that they give good results.
Thank you.
Thank you.
Dr. Somesh.
How many months you can use this cyclosporine, like for the conjunctivitis, the patient is 4 years, 5 years? Can
Yeah.
you use continuously for 2 years, 3 years?
So, we do, so because of the implications, and nowadays the patient is a consumer and have become little bit more aggressive than it used to be. So if you see all of these medications, it says, in fact, taclimin says not for ocular use, and cyclosporin says not for pediatric use. And you'll have parents coming in and challenging you, why are you using this drug for my child? So yes, so the answer to your question is yes, you can use it continuously, but because of these implications, you have to be cautious about them. So you can give a drug-free interval. So when you know, typically the parents will give you history that during these months the child is okay, but during these months it's very bad. So for 3 months or 4 months or 6 months of that year, you use that medication, and the remaining 6 months you don't. If you're from South India, you don't have much of climate change. Almost the whole year it's the same. So then you have to choose, maybe alternate to some other drug. But I have no issues using it for most of the time, for continuously for 1 or 2 years. We use it for our grafts anyway.
I had few patients who are not tolerating this tacrolimus.
Right.
So they had very severe conjunctivitis. So we usually use loteprednol. So 1
Right.
month. Again, you stop it immediately. You're using olopatadine
Yeah.
and cyclosporine, but they are not able to. But still, they are worsening.
Sometimes you
So
can
how-
keep toggling. So you, instead of olopatadine, use sodium chromoglycate. That works better for some children. Very rarely I've had children who don't tolerate taclimin. Kids don't like ointment or drops in their eyes. So you really have to figure out whether they're having, they don't tolerate it or they don't like. So you have to get that history out, and a lot of patience is required. So very few patients, they have actually dropped out of using taclimin because it stings. Very, very rare. Most of the time, the parents will say, no, he doesn't like, and you ask the child, they say, no, we don't want it, it's messy and all that. So then you switch to so if you have patients that have conjunctivitis due to taclimin in the eye, switch to them putting it on the eyelid. I bet that'll work.
Okay. And loteprednol, if you want to use
Yeah.
for long time,
Yeah.
like usually we use 1 month and then
Yeah.
we stop for 6 months. And can we use it for like that for 10
No,
years?
loteprednol, I would not use it for a long time. So my maximum usage would be something like a little bit higher. Once the allergy is broken down to maintenance, then maybe 1 drop a day for a few weeks, and then alternate day or something like that, then I would stop it. At no point would I let them go home and saying use it all the time. Whereas cyclosporin and taclimin, I would let them go home and saying, chromal, use it all the time, all year round.
Can you use Predfort in very severe cases? not
By all
responding
means, you have to
loteprednol?
use it. Again, use with caution. It's a double-edged sword. So using it for a short term will not cause. You know that it's a long-term steroid usage. So the data we have on cataract and glaucoma, it's using it for several months. So short term does not really cause glaucoma. It can cause steroid response, but not glaucoma or cataract. It is long term, and our fear that they will abuse it. You give them medication, they know it works very well for the kid. They'll go, and you know that across the counter, the pharmacists don't refuse to give even Predfort, they just give it. So our fear is about the abuse that will happen because they understand that this medication works.
Right.
So that's why we're more afraid. But under your own supervision, if you're using it, I think you can use it.
And this absolute eosinophil count and serum Ig levels, any
Yes.
impact on that?
Yeah, certainly. So this and one more question that often is asked about the hypersensitivity panel that we do, the allergy panel basically. So these 3 questions go hand in hand. So you need to do these for those individuals who have other systemic allergy, like continuous sneezing, or they have hives or the skin changes and so on. So they can have IgE hypersensitivity, increased eosinophil level syndrome. There's a syndrome actually, they're born with it. So in those patients I would do it, but not otherwise, not routinely.
The systemic chromoglycate, sodium chromoglycate, will it work for eye, like allergic conjunctivitis for the eye?
Systemic, not much. I'm talking
it's
about
a mast cell
topicals. Yeah.
stabilizer. So you could, when in severe cases, you could give it on a BD dosage, though OD is the recommended one, and you can keep them on maintenance on OD for a long period of time. And now you have bepostatin and alcaftidin also, and bepostatin, it does work well where olopatadine is not working well. It does give an instant symptomatic relief, and it's now available commercially also. Sometimes I do combine my patients with rebapamide as well, especially when they are chronic folliculitis because of the allergy disease has all probably caused an inflammation and a disease of the limbal stem cells also, an add-on with the rebapamide. But again, as Dr. Somshila reiterated, is what you need is to cause an acute immunosuppression with the steroid. The type of steroid depends upon the severity of the infection. Change to a lesser potential steroid, and don't keep them for too long because of the dangers of steroids, and change them onto steroid sparing agents.
This olopatadine you can use for a long time, like after
Yeah.
years,
Yes,
you want 5
yes,
years,
you
10
can.
years, no
Olopatadine.
problem.
Yeah. Thank you.
Thank you. There is one more question. Yeah, please.
Do
go
we have any specific prognostic factors of VKC, like which child will progress to such severity or not?
The only prognostic factor that I can think of is the age at presentation, so and the severity at the presentation.
At the present.
So if you have a child who's presented at the age 2, 3 or 4 years already with a severe kind of VKC, and they do that, then you know that this child is going to have allergy for a longer time and more problems as compared to a child who presents at 12, 13 years. Because conventionally we've been taught, and we do see that it regresses with post-puberty. So
Which mutations affect type 4 collagen? It affects glomerular basement membrane in the kidney, cochlear basement membrane in the ear, anterior lens capsule and Brooks membrane in the eye. By affecting glomerular basement membrane in the kidney, it causes nephritis with hematuria, which is a life-threatening aspect of this disorder. By affecting the cochlear basement membrane in the ear, it causes progressive sensory neural hearing loss, beginning with high frequencies. By affecting basement membrane in the cornea, causes recurrent corneal erosions. By affecting descendant membrane, it causes posterior polymorphous corneal dystrophy. By affecting the anterior capsule, it causes anterior lenticonus, which is bilateral in 25% of the cases. By affecting Brooks membrane, it causes central and mid-peripheral dot and fleck retinopathy. Coming to the pattern of inheritance, usually it will be X-linked, and rarely it is autosomal recessive and autosomal dominant. In X-linked variants, males have more form of severe disease. This is the pattern of inheritance. Males, 90% by 5 years they have end-stage kidney disease, but females only 12% by 5 years. Coming to our case, we have a female 19-year-old patient who came for open and for refractive surgery. She had difficulty in identifying faces and bus numbers during daytime from high school days. She had a habit of reading objects at a close distance, history of using spectacles for 8 years but not satisfied with them. She has a history of progressive hearing loss. Family history, her two sisters have similar complaints. Male members were not affected. Refraction shows high amount of refractor error with central shadow, that is oil droplet reflex. On examination, lens shows clear lens with gentle central bulge. This is how the oil droplet reflex looks like, and this is how the mild bulge in the anterior capsule. Anterior lenticonus is a conical projection of the lens capsule and cortex located in about axial diameter of 2 to 7 millimeters. It need to be differentiated by lentiglobus, in which the bulging involves the entire lens surface. In early stage, it looks like oil droplet reflex, but we can see in the advanced stage subcapsular and cortical opacities. Anterior lenticonus is a rare bilateral and progressive development anomaly. In more than 90% of the cases, it is associated with Alport syndrome. For the diagnosis of Alport syndrome, the presence, according to Flinter, the presence of 3 of 4 criteria are required. One is hematuria in other family members with or without chronic renal failure. Second is kidney biopsy with the characteristic histological lesions, that is thickening and splitting of glomerular basement membrane. Third is ocular involvement, specifically anterior lenticonus and macular flecked retinopathy. And the fourth is the progressive auditory involvement, specifically to high tone sensory neural deafness. In this subject has anterior lenticonus, progressive hearing loss, and similar complaints in 2 of her sisters. So this made us to think about a possibility of Alport syndrome with anterior lenticonus in both eyes. This is how OCT anterior lens surface looks like. So considering this, we ordered the investigations of audiometry, urinalysis, ultrasound abdomen, and other family members examination, genetic analysis. Audiometry shows sensory neural deafness. Urine analysis shows proteinuria, hematuria, and 4 to 5 RBCs per high power field. And ultrasound abdomen shows bilateral small kidneys with increased echo texture, suggestive of bilateral parenchymal disease. So we plan to do clear lens extraction with the posterior chamber hydrophobic aspheric intraocular lens implantation under GA with guarded visual prognosis, right eye followed by left eye. This is how the surgery is being done. I thank Dr. Murali for sharing his video. Anterior capsule is stained with trypan blue. First, a small nick is given with 26 gauge needle. Then, for better control, he is using pediatric Rexis forceps. Although the surgery Rexis might look simple, but because of the nature of the capsule, thin, fragile, and highly elastic capsule, it's very difficult to achieve very good Rexis. Now Rexis is being completed, and hydrodissection and delamination is being done, and lens aspiration is being done with bimanual IA, and lens is being implanted. The challenges we face in these cases are being highly elastic, fragile, and thin capsule. We need to use high density viscoelastic to flatten the anterior capsule. Capsular Rexis need to be started from the mid peripheral region as against conventional CCs to avoid peripheral extension. AC depth need to be maintained by proper bottle height to reduce posterior pressure on the lens capsule, and better to use a single piece hydrophobic acrylic lens into the bag for more stable fixation. So to conclude, we need to suspect Alport syndrome in all the cases of lenticonus and advise to undergo systemic evaluation along with other family members. CLE is the surgery of choice for anterior lenticonus in patients with Alport syndrome for visual rehabilitation. We need to start the capsular Rexis from the mid periphery. General anesthesia is the preferred modality of anesthesia because of hearing problem and difficult capsular Rexis. Thank you for kind attention. Now it is question time. Yeah.
You switch back to the slides here. Here's the one. Thank you, Dr. Ramesh. Before it plays, yeah. Thanks again.
That's ready for questions. Take questions. You can shoot arrows. I'm ready to break my head if you have questions. And I invite you, I invite all of you to attend Looking Beyond the Eye, that is held in Visakhapatnam LV Prasad Institute. That is eye and eye in systemic disorders.
Thank you once again for your kind attention.
Thank you very much.
To be very patient even on the last day. If there are any questions, so I appreciate your positive or negative feedbacks. So this would help us coming next year with very reloaded kind. Thank you once again.